hands to help facilitate moving them in bed. The reality is that people are not super helpful. So if you can encourage them to help you, that's great. But the reality is most of them either just are tired and laying there, or you say, I'm gonna boost you up in bed, and they go, okay, and they just lay there and do nothing. So if I'm gonna help boost somebody, typically what I like to do is I like to kind of grab the pad or the sheet kind of by hip and by shoulders, because that way that's kind of where most of people's body weight are. And the big thing to think about too is with boosting is making sure you're kind of in that athletic stance. What I see a lot with people is when they go to boost somebody up in bed, they feel the need that they have to lift them up and then position them. You're not lifting them, you're just sliding them up in bed. So even people who are way, way, way larger than you, people who are not super helpful, you would have two people doing this. So to make sure that you're working together, the bed height is appropriate, and that you can kind of shift your weight up towards the head of the bed. So you're not twisting your back, you're not pulling on them, you're just shifting from point A to point B. Make sense?
I don't know if this is very silent.
Now, you can do all sorts of things. Also some things to think about to kind of get yourself into the mindset of transfers is how somebody moves in bed will tell you a ton about how they are going to transfer. If it's taking two of you to simply hold the patient up in bed, they're probably not going to walk to the bathroom. And you need to kind of think about, okay, what's the most appropriate transfer here? At the same time, if your patient can independently bridge themselves so nursing can put a bedpan underneath them, they're probably strong enough to get up and move in, and you should be progressing them a little bit more as therapists. So what I oftentimes will do with people is basically see what they can do for themselves. You'll notice the biggest difference between therapy and nursing is nursing tends to do for the patient and therapy tends to do with the patient. So it's kind of a fine line between kind of sitting back and letting somebody struggle for a minute to figure out what they can do. I tell my patients all the time, I like you, but I'm not going home with you. So I want to make sure that you can do this stuff for yourself. So it might be, what is your name?
Julia.
Okay, somebody says, okay, Julia, we're going to get up on the edge of the bed. Come sit up here towards me. And sometimes it's like, okay, whoop. Good, okay. I'm not hands-on, I'm not having to physically help her. That tells me that she's got good trunk strength, she's got good back support, and that she can sit herself up. Okay, at the same time, lay back down then. Okay, let's say this looks like this. Okay, Julia, we're gonna get up now. Oh, can you move this leg towards me? Move this leg, there you go. Okay, this one. If anybody's never felt how heavy a dependent extremity is, they are incredibly heavy. Okay, and this way, okay. So I'm not twisting my back, I'm still bending my knees to help facilitate getting somebody up and moving. And then turning them to get from point A to point B. One thing you will also have to get over is being close to your patients. So people are gross. So oftentimes I'm in front of people, I'm using my legs to kind of hug where they are, I'm hanging onto their shoulders, and I'm facilitating making sure that they're safe. There are people too who's, for whatever reason, they just have pretty terrible endurance, they have pretty terrible trunk control, so you literally are like holding them up on the edge of the bed. And just because somebody might be this way does not mean that they are not appropriate to get out of bed. And a lot of that will come with your clinical judgment and as you have more success with getting people up and moving. So at the same time, if I'm sitting here and I'm just trying to hold her up here, probably not a good idea to walk to the bathroom if she can't even sit here. So that's kind of where those pivot transfers or the two-person or the slide board might be more appropriate.
I have a question, Amy.
Yes.
Do you transfer with physical therapy and work with physical therapy often?
Not often. Our setting in particular is really kind of frowns upon co-treats.
Okay.
I know that's not the same everywhere, but we have really, really awesome rehab techs. So if I need a second set of hands, I am not shy to call a second person in.
Okay.
So please call somebody in. I've had many times where I call somebody in and it goes better than I thought and they just kind of stand there and hang out. I'd much rather that than me get from point A to point B and think, oh sweet Jesus, this is going terrible. There's nothing worse than having a bad transfer because that patient's probably not going to want to get up again. They're not probably going to feel like they trust you to get them up and moving. I think what else?
And does everyone notice what Jamie's wearing?
Scrubs.
Yeah, comfy clothes, closed-toed shoes, tennis shoes, something she can move in, something that she's not going to slip when she's, you know, something's wet on the floor, her feet aren't going to get run over if she's transferring someone in and out of a wheelchair. So really making sure, and as you get into more specific settings, obviously there might be certain necklaces, scarves, things
Yeah,
like
you're
that.
not cute.
Oh, right.
You look cute.
Oh, well, thanks. Well, yeah, there's like no cuteness. It's about practicality and comfort. Especially too, people get kind of grabby or they can get confused. Last thing you want is somebody pulling on an earring, yanking on a necklace. A lot of facilities, especially mine in general, has rules about if your hair is a certain length, it has to be pulled back. No jewelry, no rings, no nothing. It's all just for infection prevention and keeping things safe.
So she's bending with her legs, she's not twisting and lifting at the same time, she's making sure she has a good base of support. Those are all the things that she's doing when she's transferring.
Including a wider base of support
Wide
too.
base
You're
of
not,
support.
weeble, wobbling and.
One good
You
thing
have
about this
girls
too.
down to your knee and making sure that you're covered up here, so when you're leaning over
Also that,
to help transfer
yeah.
your patient, your girls aren't in their face.
Yes.
So
Yeah.
they can't help where theirs go, but we can help where ours go.
Yes, that is true. And there are some men who will not be shy to talk to you about that, so keep them covered. So think about you're going to help boost a patient up in bed, and you're hanging onto that pad or sling. Would you use an overhand grip or an underhand grip, and why?
Palms up.
Okay, anybody think palms down?
Because that gravity would force it would slip out of your hand more easily.
Yeah, so if you think just anatomically, your biceps are a heck of a lot stronger than your forearm muscles. So I think sometimes people just grab the thing and they just do it without thinking about it. But if you take the time to think what makes the most sense, the underhand grip as you're sliding somebody up will give you a lot more leverage and strength as you're getting people boosted up in bed. Yeah, I would get her up on the edge of the bed and then put her gait belt on. So it's just a matter of going around, going through the teeth part first. And then sometimes you'll get this really long tail. I just tuck the tail in. So it's out of your way and you're not tripping or messing up. So if I'm getting, I might have you, everybody see, you guys see, move if you can't see. So once again, I'm looking at Julia. She can support herself, she can sit herself up. So that already kind of tells me that she will be a one-person assist transfer. In my particular setting, the reality is you're not in the hospital if you're young and healthy. So most of the people I see are considered geriatric in population. Most people I see have used a walker of some sort. So if I'm not really sure how somebody's gonna get up and move, I have them use a walker anyway. And if they're doing great, we can get rid of it later. But I'd rather them have the extra support than not. As far as walkers go, as I mentioned, sometimes you're the first person to get somebody out of bed. So as far as the height of the walker, where they hang on should be kind of equivalent to somebody's hip bones. So the last thing you need is somebody who's really hunched over trying to use this walker that's too tall or too short, but obviously this would be way too tall for me and it wouldn't really make sense body mechanic wise. So how tall are you?
5.
This might be tall enough for you. Okay. Well, you're not a patient right now, just get up. Okay, so can you all see how this kind of hits her appropriately? Okay, so oftentimes I will ask a patient, how tall are you? And I had somebody who was 4'8" last week, and I've had people who were like 6'6". It just depends. So if you're looking at the walker and thinking, gosh, that's going to be too tall or too short, adjust it before you get them up, because you can always readjust it after you do a transfer or get them up later. Okay, so have a seat back on the edge then. Okay, so once again, having lots of students, I feel like new therapists and students don't really know where to stand when you're getting somebody up. And it's like, here's this thing in the way, and do I hang on to you, and what am I supposed to do? So a couple of factors go into that. If somebody's had a surgery or an injury, I tend to be on that side, because that side is going to be weaker by nature. If they've had a stroke and they have weakness on one side, if they just had a hip or a knee replacement on one side, I want to be on and protecting that side. Something else to think about is, where are you going to? If we were going to get up and go to the commode, it doesn't make sense for me to be way over here because I can't even do anything. I would just be getting in the way. So as far as getting somebody up and moving, typically it works best to get them as close to the edge as they can be. If people's feet are on the ground, that tends to go a lot better. If you think about it, you try to stand and your feet can't even touch the floor. That's kind of scary to get like the momentum to get yourself up and moving. So I'll facilitate having them do it. Sometimes people can't do it, and that's when I am reaching around, still squatting, and I'm kind of bunching the pad and I'm helping to scoot somebody's butt forward. So once again, you're in people's personal space and you need to get over it. So now that she is there, I can put the walker where it needs to be. And something else that's important too is tell your patients what you're doing and what you expect them to do. Okay, Julia, in just a minute, we're gonna stand up and we're gonna turn and have a seat on the commode. Okay, so when using a walker, I like you to push from the surface you're going from. If you pull on this, all it's gonna do is tip over on you. Some people have the strength to be able to push themselves up, some people don't. So sometimes I'll let somebody kind of do one and one, but I don't let people use both, because if they pull on this, all it's gonna do is move with them and it doesn't give them enough momentum to get their butts up. Okay, so when you're ready, you're gonna stand up. Good, grab a hold here. I usually give people a second before we just continue, because sometimes people get dizzy, sometimes people throw up, sometimes, other times they're like ready to go, and you're like, hang on a second here. Okay, so when you're ready, you're gonna just turn and have a seat on the edge of there.
Turn with this?
Yep. Good. See how I can always shift where I am too. I'm here, I have contact. Okay, look up. Before you sit, reach back for where you're going to. There you go. Okay, have a seat. Good. You will also learn to kind of shift your approach depending on who your person is. Sometimes people need lots of coddling, lots of cheerleading, lots of explanation. Sometimes people just need, Julia, stand up and sit on the commode. What? Get on the commode. Okay. Done. Sometimes people, if you're sitting there, okay, stand up and don't put your hands here and hang on here and oh, not yet. There's like, what are you talking about? So, read your patients, take your time. Okay. Have you gone over like levels of assist or anything yet? Like what?
A little bit, yeah. We've started to do those sorts of things.
I said it, yeah, a little
Okay,
bit, not
okay, yeah.
no.
Okay.
They're still learning about it.
Okay. A lot of, do you guys know what I mean by level of assist?
Like mid-mod.
Mid-mod,
Mid.
max. Okay. So, how I explain this, I do a lot of nursing education too, so I'm trying to think what I do with when I teach nurses body mechanics. So for levels of assist, independent would be just like you and I. We are independent, can do everything ourselves. Setting somebody up is I'm giving them the equipment and they basically can do everything from there. People who are independent and set up don't need therapy, so you very rarely see those types of things. Somebody who is supervision is I'm giving them the equipment to do things, but I am free to be kind of hands-off and just watching them make sure they can do with that, whatever I'm asking them to do. So an example of supervision with OT is that might be a patient's in the bathroom brushing their teeth and I'm hanging out in the doorway. I'm keeping an eye on them, they're doing their thing, but I'm not right there because they can do those things for themselves. Standby assistance is that I am right by the patient, but I'm not hands-on. I am there if she needs me, I'm standing by, but I'm not touching her or doing anything with her. Some facilities will use the term contact yard, ours does not. Our facility says if your hands on the patient is automatically a min assist. So minimal assistance means the patient is doing 75% of the work, I'm doing 25%. Moderate assistance is we're kind of 50-50. Max assist is I'm doing 75% of the work, the patient's doing 25%. And then dependent is you are doing 100% of the work as far as getting your patients up. So once again, if I'm looking at how much assist somebody is getting up in bed, if they're a max of 2 to sit at the edge of the bed, that type of transfer is probably not going to be realistic or probably not going to be happening. So let's have you sit back on the edge of the bed. Okay, so for example, if somebody's a higher level of assist, I don't even use a walker. The walker is in my way and it's one more thing that's kind of scary. So let's pretend that Julia is like a moderate assistance. She can still get up, but she still needs quite a bit of help to go from point A to point B. What I oftentimes will do is I cue patients, sorry my hands are always freezing, is I cue patients to hang on to my biceps. And this way, they have support almost like if they were using a walker, but it still gives me free rein to move my arms to hang under the gait belt and do what I need to do with that patient. So oftentimes it looks like as we stand, like we're gonna do a dance from point A to point B. So if somebody's a mod or max assist, you can probably bank that they'll have enough strength to push their butts and get them up. So that's why I just put their hands on me. What I also find is I don't tell them where to put their hands. Then they're like, here, what's happening? I'm like, nope, right here, right here. Okay. So I put them here. Once again, kind of butt out, wide stance, and we're gonna use the gait belt. This already to me would not be tight enough, so before we stand, I would tighten it. Okay, okay. Okay, Julie, we're gonna stand up. Here we go. Up we go. Good. So from here, I'm giving her support. I have control over where her trunk is going, and she's hanging on to me. It's probably hard for you to mimic what a modicis looks like or feels like.
Yeah, just
So oftentimes, we're just kind of like, hey, we're gonna take a step. Good. Take a step. Good. Take a step. And then once we get from point A to point B, I will kind of cue her. Okay, Julia, take your hands off me and find the toilet. Good. So do you see as I'm lowering her, I'm moving with her. My butt is out. We are sitting together. Okay, you're all like, yeah, okay. If you're getting the patient out of bed and on the commode, does it make sense to have the commode at the foot of the bed or head of the bed, and why?
What was the question?
If you're getting the patient out of bed, they have to use the commode. Would you put the commode at the foot of the bed or the head of the bed, and why?
It would depend on what their affected site is.
Well, so they don't have an affected side. They're just old and weak.
Oh. I would say the foot.
I would say the foot because
foot. And a different pin on it.
in all reality, the head of the bed, we're gonna have all of that.
Monitors and stuff.
Yeah,
Like,
so you're
I
gonna
think
wanna,
it's their preference, really.
So positioning and how you're gonna get them on it would be easier to find their feet.
there's less stuff in the way going this way.
Yeah.
So-
Depend on
You
your,
have the bed rail that helps push from the surface. If it's
Okay, so
if you're right or left.
yes, I felt like you for years, and because the reality is the bathroom is here. I would bring the commode out and just put it here and get somebody up.
Mhm.
But what I was finding, you can stand up for a second, is I'm getting somebody up and out of bed. This is in the way of me trying to get them up. So you're really going from here, way over to here, to use the bathroom. And oftentimes you're sitting here, and if I've got to swing their legs in the bed, this is in the way. There's nothing worse than trying to gently move a full commode out of the way. So, head of bed. So if you look at the head of the bed, I also realize that there's IVs and there's oxygen, there's stuff there where you can still move it out of the way. So do you see how much easier it is for me to just sit
Yeah.
and go from here to here
Way more sense.
and get up? So that took me like years to realize. I was like, oh my gosh, that makes so much more sense.
That's probably mine.
That's okay. Probably mine. I shed a lot. Okay, so she has that list up there that like none of you
Yeah,
can probably see
wheelchair
back
to
here.
wheelchair with left-sided neglect.
Okay. What can you guys tell me about left-sided neglect? What does that clinically look like?
Just ignoring your left side, right? Just not using it.
They're not aware of the left side of their body. So they're not looking in that direction.
I remember too, like learning about these things, and I feel like learning about it and seeing it in real life are also very different. So do you want to practice? I guess in my mind, if somebody has really severe left neglect, I would probably still transfer them to their right until they get to the point where they could be safe doing it. But I'm guessing you want to practice going to somebody's left.
No, you can definitely practice going to their non-affected side. That's absolutely appropriate.
I need my lefts and rights going here too. This wheelchair would probably be too low for somebody like you.
Carla also wants us to practice it to the weak side.
Yes,
Yeah.
we'll talk about that too. This is like a junior height baby wheelchair. This is like a normal person one.
Why would you possibly have to transfer somebody to their weaker side or to their affected side? Why would you? Why do you?
They're getting
think-
off space.
On or off the toilet, right? Cause you'd have
What'd
to
you say?
Environmental barrier.
Right.
Yeah, like if the toilet has a huge wall here and they have to go this way,
You don't
they
have the
can't come
option.
this way.
Right.
So some things to think about is typically if somebody has a weaker side or affected side, it is typically harder to go back to bed. So if I can, I will transfer them to the weaker side to get up. That way they have the strength and they have their stronger side to get themselves back into bed. For some of these patients, you would not believe how incredibly fatiguing it is to sit up on the commode for 3 minutes and get back into bed. And there's nothing worse than getting somebody stuck on the commode or too weak to transfer and get from point A to point B. So when you are getting somebody up, I like to put wherever we're going to as close as I can to the patient. And then you obviously want to make sure your brakes are locked. So if she truly did have a really bad left neglect or a really weak side, I would not be doing this by myself. I would probably have a second set of hands. And either I'd be hanging on to her while somebody's getting the equipment set up or vice versa. So let's talk about neglect first. So if a patient's neglecting their left side, in their mind, in reality, it's not even ignoring it. It does not exist. So if her neglect is to the point where I've seen people who their neglect is like midline. So when they're looking at something, they get to midline and they genuinely think that midline is the left. So I'm asking them, okay, Julie, we're gonna get up into this chair here. She has no idea where the chair is. Cannot see it. She thinks I'm insane. What are you talking about? There is no chair. That automatically kind of increases people's anxiety levels. They're kind of think like, what are you talking about? People who have the neglect versus like an actual visual field cut, it's really hard to convince somebody that something's there because they generally don't think it is. So for more success, I would typically either try turning like somebody's head or even try like tactile to get somebody to realize that this is there. Just because somebody has a neglect does not necessarily mean they have a weakness either. So let's just kind of think about the neglect for getting up. So if I was going to get her up, I would probably kind of cue her and get her looking in the direction of where we're going so she sees like, hey, this is actually here. I'm not making this up. And then, so once again, if we're going to get somebody up, this is a two-person, let's shoot a sofa with, 2 stations.
Yeah, just to the non-affected and to the affected side.
Okay. Okay, so if it was like a neglect, I would try to visually cue her to see where we're going. So once again, I would have you scoop forward so your toes are touching the ground. Okay, so she can hang on to it. It's a real thing versus me just trying to tell her and pretend that it's there. So when you're getting somebody up, I always stand on the outside leg. And that can be kind of scary for people because people feel like you're really far away from the surface where you're going. But if I'm in here, do you see how I'm in the way and she has nowhere to go? So I always will stand on the outside area. That's different than somebody who has a weakness. So we're just talking about neglect for right now. Okay, so if we're gonna get somebody up, I would still kind of stand. Then if I need to, I would cue as we're moving to get from point A to point B. And can you feel how much assistance I'm guiding you with just simply using that gait belt?
Yeah.
If somebody's neglect is really, 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 really bad, I would just simply transfer them to the right because you can work on a lot of visual scanning, ADL type goals from seated sink side, in a chair, in the bathroom. So it kind of depends on where you are. The transfer might not be the most important thing at that time. Simply being out of bed and working on skills from seated might be a more appropriate goal. So this way we're getting back into bed, which is going to be harder. We just did a 30-minute session. She's tired. She thinks I'm crazy. I'm making her do all these weird things. She can at least see where we're going, and it makes it a lot easier as we stand up. So I'm going to have you push, lean towards me. Good. Turn.
Yeah, you have
Have a seat.
control with that. Feels like you had more control of my body than I did.
Could you just tell her to push down with her hands?
If I usually say push up and we're going to stand.
Okay.
So why would you put the wheelchair on the end of her legs rather than her head side, like you did with the
Cause there's
toilet?
no hook or feet in there.
No, I mean to swing, if she was starting from a laying down position, would you still put that there?
it
What's the
doesn't-
difference?
Well, this I can go like this.
It's easier to move out of the way.
It's easier to move out of the way if you need to. She's able to stand and take a step, so that's a little bit different than somebody who you really need to facilitate swinging their legs up and in. Does that make sense? I answer your question? Okay. So let's talk about somebody who has left-sided weakness. So weakness and being totally flaccid are very different things. So somebody just might be, just a little bit weaker. What that might look like is they don't have a ton of strength to maybe push the stand. As they go to stand on that leg, they can bear weight, but it might be kind of wobbly as you're getting somebody up and moving. Versus somebody whose extremity is flaccid, that's like nothing. And like I said, if you've ever felt a flaccid extremity, legs and arms, legs especially, are super heavy. So if you're having to facilitate and move somebody whose extremity is flaccid, you want to take care and protect that extremity. So if she was somebody who had a really, really flaccid extremity, I'm guessing that her trunk's probably not the greatest. I'm guessing that her sitting posture is probably not the greatest. So I would probably have 2 people in here. What's also really nice about wheelchairs and why I think you should be familiar with them is with wheelchairs, you can swing the armrest out of the way. And why that's really important is because you now do not have to get her butt way up and over the armrest. You just have an easier way to go from point A to point B. Okay. So if somebody's extremity is flaccid, I'm probably not going to transfer them to that flaccid side because that's just going to be terrifying for people. So we're going to pretend that this side is your flaccid side. I also move people's legs where I want them all the time. So don't be afraid to okay, you go here, this goes here, I'm going to be over here. Okay, so we're shifting, so she has a right side that's flaccid. If somebody's arm is really flaccid, 9 times out of 10, I will go and get an envelope sling, just like a regular sling, and I'll put that arm in the sling. That way it's out of my way, it's safe, it's not gonna swing and hit me, it's not gonna get stuck behind somebody. I can see it, I know where it is. We're gonna pretend this arm is in a sling. This leg, I will oftentimes, come here, you guys can't see, let me move this for a second. I hug and position a flaccid extremity within my own legs. I have control over where this leg is going. If I'm way over here and this leg is flaccid and we go to stand and move, guess what? That patient's going down. But if I'm here, let's just pretend that you try to stand and kind of let that leg go. Do you see how much control I have over, I would never stand somebody like this, but do you see how much control I have over where that leg is going? If I'm way over here and that leg starts going, it goes right between my legs,
Right through, yeah.
we're both gonna go down. It's not gonna be very fun for anybody.
Have you seen that happen?
On occasion, but
How is that straddle that you just did different than the other straddle? 'Cause I thought you said that the neglect one, where you straddle the leg, was only for neglect. Did you just straddle?
I wouldn't- I feel like I naturally kind of straddle people, but that
Okay.
sounds really bizarre. If somebody has a neglect, I don't necessarily need to be protecting them. I'm just kind of here. So for the neglect, it's just you're gonna be on the side or furthest away from where you're going.
Okay.
If somebody truly has this is 9 times out of 10, it looks like this. So you need to actually put it where you want it to go. So I would be positioning it where I need it to be.
Oh, thank you.
Okay, I'm here. So with this, she doesn't have any issues. Sometimes this is too far of a reach for somebody who really has poor balance. So I would tell somebody, okay, Julia, as we get moving, your arm is gonna be reaching way over for that armrest. So I oftentimes too will cue people and I'll have them really lean into me. So then as we're transferring, okay, we're gonna go over. I am using the balls of my feet to pivot somebody from point A to point B. I'm not bending my back, I'm not reaching around somebody, but I can use the gait belt to then easily facilitate where we're going from point A to point B. If we were gonna get back into bed with somebody who truly had a neglect, I would turn the wheelchair around and do the same thing so that she's gonna get up towards her non-affected side. Any questions about that? That was kind of a lot. You'll see your people and be like, what was she talking about again?
When your
So-
legs are protecting that affected leg, are you squeezing, giving some pressure there to make sure?
Come and sit. Is that like what? Oh, they're tall. So yes, I'm squeezing it
And guiding it?
and guiding it. So even here, if let's say it's not totally flaccid, but it's still pretty weak, and we get somebody on the commode, and I'm trying to get them to stand up long enough. One of my goals is patient will stand for 20 seconds with moderate assistance to help with peri-hygiene. So even if that's weak, when we go to stand, okay, you're gonna push up here. It might even look like this, and you can feel that I really have control over where that leg is going. Let that leg kind of buckle, towards me. There you go. I'm not letting it do it because I'm there. If I'm way over here, that patient's gonna go down. Even though I have good body mechanics, if I'm not protecting that leg, it's gonna shoot right through mine and kind of go towards the floor.
Can you block it?
Hmm?
Can you block
To me, that's what I'm doing.
their knee?
Yeah, that's what she's.
But not like, yeah, not doing that, but like blocking with your one knee while you're squatting.
I usually use both of mine because I feel like if I'm just one-on-one, if that leg moves, it's gonna slide.
I guess
Do you
depending
know-
on how
yeah.
weak that leg is, you know what I mean? Cause sometimes it's just like a block.
Yeah, so are you saying that like if somebody has like a rocking horse gait, you're gonna fix that on your own? Like you're gonna move the joint on your own? Is that what you're saying? Like if it,
No, just blocking so it doesn't buckle.
So
Your
I'll show
knee
you.
is braced up again, but
I'll show you. Okay. So, if you were going to be standing, I have Viva on. So as you stand, I'm moving where that leg is going because I'm there.
Yeah.
So if I'm here and that leg goes to buckle, it's probably gonna look like that and it's gonna go down.
Okay.
Answer your question?
yeah.
Yeah.
Yeah, I was more looking at like, I get the knee and stuff, but the foot too. Right, like are you kind of guiding your feet with their foot?
Right, because as we're pivoting, that leg just kind of actually moves along with you.
Oh wait, but another thing, if both of your legs are supporting the knee, you don't really have base of support. You have a narrow base of support, so you're more apt to losing your balance and transferring something this week. Versus if you have your leg out and you're squatting and you're blocking that knee, you have a wider base of support. That's
No, because as we're going still, 9 times out of 10, like, we're just going from point A to point B. So, we're here.
It's like a little dance.
That's how practice is weak, I would be blocking it. So just because somebody has a neglect does not mean that that leg is weak. I've had people who are totally independent, who are talking to you, who put that there? That was not there 5 seconds ago. So they're up and moving, but they have a neglect and they are not seeing things in the left area. So somebody might be very mobile, but still have a neglect. And because of that, you need to be positioning yourself safely to get them up and moving. That is different than having weakness or a flaccid extremity. If an extremity is totally flaccid, they cannot move it voluntarily at all. I am always blocking it. If somebody is just a little weak, I would still kind of position myself on that weak side. But as we're getting up and standing, you can kind of tell what's happening with that leg. So if I feel like it's getting kind of buckly, I might have them sit down, readjust myself, and prepare to block it a little bit more. Or if it's just weak, so kind of like we were just talking about. So I'll have you have a seat here a second. So let's say her left side is weak, but it's not flaccid. So I might be getting her up to stand. So we can stand up. Yeah, there you go. Okay, stand up. Your hand to me. Okay. So if it's weak, you're not. There you go. So it might just be like, hey, we're gonna take a step to your right. Take a step. Take a step. Take a step. Take a step. So she's weak. I'm having to provide assistance for her, but she doesn't need me in her weight hanging on to her because she can stand and bear weight through that extremity. Does that clarify things a little bit?
Yeah.
Any questions about that?
Diagnoses that you might be given as you're doing the sliding board transfer. So for this one, it could be some level of a spinal cord injury that allows full use of both upper extremities and control of the trunk from the rib cage and above. Or it might be used for a non-weight bearing orthopedic issue of the lower extremities, for lower extremity amputations, or for a safety measure for transferring clients with neurological impairment. So those are the kinds of diagnoses you want to keep in mind as you're practicing this transfer.
Raise your hand if you feel really comfortable and love a slide board.
Never used it in my life.
Okay. I think most people are terrified of slide boards, and most patients are terrified of slide boards. I had a lady this week who was 5'4", 360 pounds, and non-weight bearing on her left lower extremity. And she was like, girlfriend, I'm gonna break that board. And I said, I've never had somebody break a slide board. But once again, if you go in there and you take your time and educate and walk patients through this, they have a lot more confidence with you doing the transfer. If you're kind of like, oh, I don't know how this is gonna go, it's probably not gonna go well because the patient's like, you don't know what you're doing and I don't really feel comfortable with you getting me up and moving. Slide boards are your best friend for really heavy patients. So let's talk about what you would do the slide board for. Slide boards are for people who cannot stand up for whatever reason. Maybe they're just so weak and deconditioned, there's nothing neurologically or orthopedically wrong with their legs, but they're just so deconditioned and weak that they just can't stand, they're just so tired. Slide board might be appropriate. Somebody might be non-weight bearing. I don't care who you are, how old you are, non-weight bearing is super hard. Most of the time, these are overweight, elderly people who now you're asking them to stand up and hop on one foot to get from point A to point B. It's not gonna happen. Or you have the people who maybe they have the weakness or the flaccid side, and let's say that you all practice the flaccid side, it's hard for somebody. Now imagine your patient weighs 300 pounds more than you do, and they have a flaccid side. That changes things a little bit. So it doesn't mean that they aren't inappropriate to get up, but you have to think clinically about how we're gonna do this. So, for a slide board, a couple things to keep in mind. I like to make sure that my surfaces are as level as possible. I would never do the slide board transfer because getting back is gonna be way too big of an uphill. So if you're getting somebody up, I would try to raise the bed or lower the bed or put a cushion or something to make sure that you have a more even playing field to go from point A to point B. This is probably personal preference, I never do a slide board by myself. If somebody is that level of assistance that they need to use a slide board, I always have a second set of hands in there. I don't care if that second set of hands is a standby assistive one. Maybe they're just in charge of the lines, and they're making sure the IV, the catheter, the oxygen is moving as we're doing there. I just never do one by myself. So, with that being said, you can come back up, or if somebody else wants to volunteer. I'll volunteer. Okay. Well, you can be my second person though, Julie, if you like. Okay, so you can be my patient. Is it better if I transfer this direction so you can see what we're doing? Okay. So if I'm getting somebody up to do the slide board, I typically will have one person in front, one person in back. So to me, the person in front is the one who is going to be, I always use the sheet or the draw pad, and I will lean them to their side. So when you're placing the slide board, the goal is kind of underneath somebody's butt cheek. So if you have heavier people, there's a lot more tissue and stuff you're trying to move out of the way to get the slide board positioned appropriately. If you have men, please do not jam the slide board underneath there. They do not appreciate things getting pinched or crushed. So typically, I would have one person in the front leading the patient, and I would have the back person positioning the slide board.
Is this up front or this way? This way?
I think they're this way.
Okay.
Yeah, so this one has a little bit of a downhill. Okay, so as I'm leaning, you are going to be positioning that board underneath her butt. And it can really be as quick as that. We're gonna lean, position, okay, there we go. You also wanna make sure that the angle of the slide board is where you want the patient to go. If it's way over here, guess where that patient's going? If it's way over here, guess where that patient is going? So you wanna angle it to the direction of where you're gonna be putting that patient. This is probably not the best position for you now. Okay. As you can imagine, bare butts do not slide on slide boards. So if you need to, underwear, brief, sheet, pillowcase, plastic baggie, something needs to go with that patient from point A to point B. Patients are terrified of slide boards because they think, you want me to sit on what, and we're gonna go where? So once again, as you're educating people to go from point A to point B. Also, I have never had a slide board go 1, 2, 3, and we're in. Usually it's here, and then we're here, and then we're here, and then we're in the chair. So don't be afraid to have it take multiple steps to go from point A to point B to make sure you're safely getting the patient going. So once again, if they're a slide board transfer, they probably are really weak. They probably have poor trunk control. They probably aren't able to assist you much. So as far as getting somebody up and moving, I would have a sheet, a pad, a something underneath them. She would have a gait belt on because for safety, we just need gait belts on all of our people. But to do this transfer, I'm not even gonna touch the gait belt. It's just on her for fun. So she had the gait belt on. Okay, so if I was your back person, you would then be over here. I wonder if we can, are any of these beds lower? You have a little bit. If you're getting somebody up on a slide board, you have to move the armrest out of the way because the slide board is going to hit this. So our recliner chairs in the hospital have the capacity for one of the armrests to drop out of the way. Wheel chairs, you can move whatever side you want out of the way. So I will typically take this whole thing off. We're gonna lean to the side, lean, tucking, okay. The back person then would come along the back side here. If I'm the second person doing a slide board assist, I would typically get a pillowcase, a towel, or something, and I put it on the bed and put one foot on it. I am in gross stuff all day. I do not want somebody's gross scrubs and pants in my bed, and I'm getting back into that bed. So I tend to put something down.
Yeah.
So the back person is going to be the one who's kind of facilitating moving that person from point A to point B. So you're not twisting, you're not shoving them in there, but you're there to kind of help guide. So at our hospital, we had a PT who called it the fanny swisher. And that's literally your job, is you're moving somebody's butt from point A to point B. So if you had, we'll pretend you have that going there. So I would get this as close as I can be here. Okay, once again, even though I'm not necessarily blocking a leg, I still want to be on the outside. If I'm here, she has nowhere to go and we're in the way. You're going to cue your patient as you're doing a slide board to eventually reach for that armrest, although they're not going to be able to reach it initially, and that's kind of where those phases come in. Every patient wants to hang on here. They always grip the side of the slide board, and as the weight shifts, they're going to crush their fingers.
Yeah.
So really make sure that they are not. And once again, if you're worried about it, this is going to be your best friend. They're going to just hang on to you here. Okay, so we're going to actually use the pad as we're sliding her over. So once again, I'm on their outside. I'm having her lean towards me. Okay, we're going to slide. Good. Okay, reach your hand for the armrest there. Okay, there you go. Right for here. Yep, one more big slide. And then once you're there, we can kind of do a quick little whoop, whoop. That's okay. Getting back to bed is always harder. So if you have the capacity to go towards the stronger side, if they have one per se, position the chair so you're going back to the stronger side to get them up. So once again, I would be the one to, hey, we're gonna just, okay, put your arm here, we're gonna lean and get that board underneath your butt. Good, okay. Getting back to bed, typically that back person will kind of help me get the side board started. Once the patient gets probably 3/4 of the way on the bed, I usually have the back person run around the back side of the bed to really have more support to get them up and moving. Okay, so from here, we're still gonna use the pad and find it. Okay, we're gonna do a big slide. You lean towards me. Okay, 1, 2, 3, scoop. Okay, a big scoop here. So once again, if your patient is really, really dependent of two, don't leave your front person hanging. So, no, you're okay, but, so once we get kind of all the way on here, okay, so then, once you're in the back, you have more control over the two of us to slide her butt back on the bed more.
Okay.
So if you're hanging on the sheet, we're gonna slide her back towards you. 1, 2, 3, scoop.
Alright.
I know there'll probably be lots of questions as you actually practice this. Does that make sense?
Yeah.
Any questions before we start practicing?
So what did you say I should have done before leaving? I should have.
Nothing necessarily, but just make sure, like, if your patient's a really heavy assist,
Okay.
don't like abandon
You're
your
good?
front person.
And
Yes.
then kinda.
Okay, you got her while I come around back? Like, yes, okay, I got her, and then
Okay.
kind of a quick thing.
Okay.
Do you use a sheet even if they have clothes?
Yes, I always use something.
Would you ask if she uses the sheet even when they're dressed?
And then you just keep the sheet, they stay sitting on the sheet on the
Chair.
wheelchair for the whole time until they get back into bed?
Yes, once again, this is my setting though, so everybody in the hospital is sitting on something because a lot of people are incontinent or have wounds and all sorts of other things.
So you're gonna practice from chair to chair without something, just because that's how your practical is gonna be. So take all this information that Jamie's giving you for going into your level 1s and level 2s very seriously, because it will likely be practiced like that, but for your practical, it'll just be chair to even chair, and you won't have like a sheet or anything.
Okay, so let's
Jamie's
practice
is
that
real
then.
life.
Jamie's is
Like,
real life.
Jamie's is real life, this is
Practical.
Let's move
practical
this
stuff.
Yeah.
Okay, so let's talk about if we had that. So you would have a gait belt on. Either way, you would have a gait belt on. But yeah, my people never have clothes on, so this is like weird. And I mentioned this a couple times, but I can't remember if I said it ahead of time, but regardless of your transfer, I like to get people as close to the edge as possible without making sure they're gonna tip off. So if that's in the hospital bed, or in the hospital, or wherever you're going, I would scoot them close to the edge. If they are in the chair or wheelchair, it's really hard to transfer somebody who's sitting way back here. Scoot them forward and have them sitting on the edge to make your transfer go a little bit smoother. So I would have her on the edge. Okay, so once again, when you think about kind of anatomy, always kind of ask or tell your people if you're gonna put hands that you don't usually put your hands if you just meet somebody. So say, okay, I'm gonna kind of reach underneath your bottom here, we're gonna lean to the side and place that board. Okay. So then you would come around the backside here. You want them doing 1 or 2 people with this?
Just one.
Okay, so I would probably still cue them to hang on here. And then once again, I'm standing on the outside, I'm hanging onto the gate belt. This is probably an instance where you wanna make sure it's pretty tight. Okay, and I like to keep my head on the outside because they can see where they're going. And I feel like you should know, once you do this enough, if I'm way over here trying to help, she's like, what are you doing? Where are you going? But if I'm here, she can see where we're going. And I'm using the gate belt, we're gonna just slide. Okay, reach for the armrest. Okay, keep sliding. So same principles, body mechanic wise, you're in that position and you're kind of on the balls of your feet as we're sliding to get from point A to point B. If you start trying to step and go like this, you're gonna get in their way. So then the same thing back. We'll just keep it there, I guess. Here. I'm on the outside. I'm cueing her to hang on to me. I'm having her lean into me. She's seeing where we're going. Okay, we're gonna do, you're helping too much.
Oh, sorry.
Okay. And you're just,
Okay.
little slides from point A to point B.
Okay.
You're not lifting your people, you're not bouncing them up, you're sliding them up. Slide board.
It's not a bounce board.
Like, do you stabilize like the board so it doesn't move with her, or would you have her do it?
I try to position it so it doesn't move with her. If you start getting your patient up and the board slide down to place, you did not put it in the proper position. Stop, repause, retuck it where it needs to be. 9 times out of 10, if the board's shifting a lot, it's not underneath their butt enough.
Why are you on one side versus another side? Because, I don't know, I'm thinking of the wire basis support again, and that makes me nervous being like so narrow, I guess. I don't know, is there like a, reasoning behind the different sides that you're,
Like where I'm standing for her.
yeah, like.
So I need to be on the outside. If I'm here and I'm trying to slide,
She can't see.
I'm in the way, and she's like her legs and mine are gonna get tangled. Versus if I'm on the outside and we're moving, she has a clear path for us to get from point A to point B.
What if that right foot doesn't move out of the way, and then you get stuck though?
I would be transferring her to a different side. I would go the other direction.
Alright, let's practice.
Woohoo.
And tucking. So you can kind of see too, like sometimes you really need to like get underneath somebody's jam, like you really need to lean them to get that board up.
Okay.
Good video. Never do both, but you're all going
here,
to. Yep. So then once you feel like you're
And
safe,
then you
you
grab
can.
it.
So.
She's not.
Okay.
And then I lean you back here.
So if she's sitting on it, you still sometimes can do a little wiggle room to get it where
Right,
you
to
want
get
it to be.
go here.
But if you start going and the whole thing's moving with you, it's
Right.
not underneath her butt.
Right. Okay, so then this is when I start scooching her this way. Yep. And then I have her lean this way.
Okay. You would switch and try it on the outside.
Switch.
There you go.
And then
So can you see how people have a tendency to like hang on here?
Yeah.
Because they feel scared. So I'll either cue them to put a flat hand on the board, or I'll just make them hang on here.
or maybe
So I would rather your butt be on there, and then I can kind of guide you back like that.
Okay, yeah, that's a good idea. I guess let's just first talk about what a stand pivot is. Stand pivot patients are patients who can stand. They are not taking steps, you're not walking with them. They are standing and almost like you're doing, pivoting from point A to point B. So let's not even talk about the diagnosis yet, let's get the body mechanics down. So once again, I would have somebody scoot, or I would help them scoot to the edge of where they're going. So once again, personal preference, I like to be on the outside so they have room for where to go. So if somebody can stand, you can already assume that they have decent trunk, they have decent upper body, so these people should be people who are able to help you. but maybe it's an endurance issue. Maybe I've had patients who stand really well, but when it comes time to shift weight, to actually take steps, that's where people kind of get tripped up a little bit. So these people should be able to help push the stand, and then once again, as we're going, I would kind of cue them to hang on to me. If somebody's pivoting, I probably would not use a walker because the walker would get in the way as far as the pivot goes. So I would cue them, okay, we're gonna stand up here, I'm gonna be using the gait belt. It's like a super low gait belt.
Sorry.
Okay. I kind of aim like belly button-ish when putting gait belts on. Okay, so I'm gonna have you push. We're gonna kind of push the stand. So good. So as we get somebody up, so if these people are standing, I don't need to block their leg because I'm gonna just push them and keep them off balance. These people are able to stand. So once again, so they feel like they have somewhere to put their hands, I typically will just kind of cue them to be here. So as they're standing together, we're just kind of going from point A to point B. It might feel a little forceful, I guess, but it's typically like an up and we're there. We're not standing there for 10 seconds as we're getting from point A to point B. So getting back, she probably would have her other arm rest on to help push. Okay, we're gonna stand up, turn, sit.
So you don't,
They're fast.
you don't tell them to reach back for handles or anything, you just,
Typically I would, but sometimes, I guess it depends on where we're going. I feel like people's natural instincts too, even if they're hanging on to me, is they will naturally put their hands back to sit from where they're going. But either way, even if she doesn't, she still has a lot of, kind of partially stand. So we're gonna get back on the bed. She still has a lot of control hanging on to me, that I'm making sure she's safely getting down, that she's not gonna just plop.
So if she's just doing the pivot and not stepping, where should her feet placement be before she gets up?
Good question. Let's say PT got your patient up and said, oh hey, they were like a minute assist to stand. And you go in there and you cannot for the life of you get your patient up. 9 times out of 10, it is because their feet are not in a good position. So think about it. Sit where you are and try to stand up if your feet are not out underneath you. It's really hard. So for good foot placement, I will cue them. Tuck your feet back underneath your butt. If for some reason they can't, I will manually move people's feet and so they are in a good position to be able to stand and get their butt up from point A to point B. So as far as positioning goes, so I think I'm just naturally close to people. It doesn't necessarily mean I'm blocking or hugging. Okay, we're gonna be here, stand up. So that way we are still in a good spot that as we move, I'm not getting my feet tangled up in theirs. Any other questions about stand pivots?
can you show a squat pivot? It's on a separate list. It's not one you're gonna be tested on, how about that? But it's one that Carla wanted you to be familiar with.
Okay. So squat pivoting people are people who cannot stand, but maybe they're doing a little bit better that you don't necessarily need the slide board. Maybe they are your 90-pound old lady or somebody who doesn't have the strength, but you can easily get them from point A to point B. So you're not gonna be really heavy for me to do this on necessarily. So squat pivots, once again, I'm leaning people in and we're gonna be just squatting and lifting somebody's butt from point A to point B. So same body mechanic premise, I'm here, I'm usually on the outside, and we're just pivoting to go from point A to point B.
So there's really no difference then, I'm just.
Yeah, can we just see the other one one more time? No, I
The
haven't
squat or
watched
the
that.
stand?
The stand.
Sure.
Just to see it again.
Only difference is your patient can stand, turn, pivot.
Well, I mean, from the initial one that you showed us in the beginning, there's.
Not really any difference.
Yeah, okay. You're just bending your knees more. It's fine.
And they're staying in the squat position.
Yeah, so these
So
people
that's
are, they're unable to
Yeah.
stand themselves.
But she's actually like moving her feet, whereas a pivot, they won't be able to like weight shift a step, right?
In all reality, typically people probably will take a couple small shuffles it's not like you're in trouble if you didn't do an exact pivot. As long as you're getting them kind of safely from point A to point B, but you're not actively ambulating or taking steps. A lot of these things I feel like it's just, okay, we're gonna lean in and we're gonna just go. That's also the point of your level 1s and 2s is to practice this.
Okay.
But I feel like if you're like, okay, put this foot here, and then put it here, and then do this, and then hang on here, and your eye go here. It's
We're
like,
just learning the basics.
And that's what we've said to a couple of the groups. So you're going to be tested on, are you demonstrating proper body mechanics? Are you aware of some of the precautions of some of the diagnoses? Are they able to bear weight? Are they unable to bear weight? Are you positioning yourself in a
So let's say if you're kind of debating, well, do I squat pivot this patient or do I slide board them? There's really no right or wrong answer per se. If you get somebody up and you did a squat pivot and you thought, oh my gosh, that was really hard, slide board them back.
Okay.
If you get somebody up and think that could have gone better, do a different method next time. You don't have to, why did a squat pivot forward, I gotta do it back to back.
Right.
No, you don't. So if I was gonna do a squat pivot versus a slide board, you still need to be pretty in control for somebody to do a squat pivot. If somebody is way bigger than me, they're really not helpful, it's not safe for either of us for me to try to lift them to get them in. I would do a slide board. So if somebody's like a max assist or borderline dependent, I would never squat pivot them. I would do a slide board to make it safer for both of us.
How would this change if somebody had a neglect on one side?
For doing what, squat pivot?
Yeah, or stand pivot.
Once again, depends on your patient. So like I said, if a patient's neglectful, but they can be really ambulatory, you're more so looking at their level of assistance as far as getting up or down, and then your verbal cues will come more for the neglect. So I might not be verbally cueing her as far as how we're gonna stand, but I might be verbally cueing her that we're gonna look this way or reach your arm for this direction.
And that's what we'll be looking for. Are you aware of the deficit? Are you able to provide that appropriate cue that shows that you're acknowledging that there's that deficit and you're addressing it?
Patient when I first started whose BMI was 107. And so I learned that day your BMI can be greater than 100. I did not think that was possible. And this patient walked themselves into the ER
Really?
and had a whole slew of issues. And so obviously somebody that size, 2 people is not enough. So if that's the case, that's oftentimes an appropriate co-treat. You're having your rehab techs in there. Sometimes that's what we determine people who need appropriate amount of skilled hands helping the patient. But you better bet we got him out of bed. We slid board that gentleman. He sat in the bariatric wheelchair. We got him standing with the bariatric walker. There's all sorts of stuff to do for these people. I'll write them on the board, but I'll demonstrate and say, okay, with your hip precautions, you cannot bend forward. So usually I'll say, if you think about a 90-degree angle, when you're sitting up, you already are at 90. You cannot bend forward. I'll say, the doctor also does not want you crossing your legs. You cannot turn your hip inward, nor do we want you swinging that leg out to the side. So for the most part, that leg is going to stay straight. So let's see, wheelchair to toilet. Okay, yeah. So based on what we just practiced, if these patients are not necessarily ambulatory, but we're going from wheelchair to commode, what method or type of transfer might be appropriate for these types of people?
Stand pivot?
So the idea of the stand pivot, yes, but we also gotta be careful that we're not pivoting that patient because they can't rotate on their hip. So this might be one of those where we're standing and kind of baby step, baby step, baby step, having a seat. So.
And what's that called? There's,
Just
Stand, baby, stand, baby.
I wouldn't even, like, if I'm gonna document this, I would say wheelchair to commode transfer, mid assist. You don't have to necessarily say how it happened
took many
per se.
steps between.
Yeah.
Did you say min assist?
Like just min, mod, whatever level of assist she is. So if she had a total hip people are people, especially you wanna make sure they're at the edge of the chair. So they're already in a good position. Also, some things to think about with total hip patients is you really wanna make sure that the toilet height and the chair height are tall enough. Because if you think about, if you naturally stand, people naturally bend forward. If you hurt, people tend to wanna hang on and bend forward. That's too much bending at the hip. So if in real life, I would have put you in a taller something on a cushion so that you would be a little bit taller. So also some things to consider. Total hip patients are elective surgery patients. That means that these people, 9 times out of 10, chose to come in and get their hip replaced. The fact that they know they're having surgery, they know they're gonna have therapy, and they know there's a recovery process is very different than somebody who acutely had a stroke, had a heart attack, had an aneurysm. So these people typically they were living at home before coming in here. So the fact they were living at home and able to get up and move, they should be easier to get up and moving as far as transfers go. So when getting patients up, I usually will have them go towards their operated side. So because of that, the operated leg isn't having to go as far. And then once again, getting back, which is harder, you're going towards their strong side.
So
Okay.
that's what you guys are gonna wanna remember for the practical.
And I can say that again if you wanna write that down.
When possible, when you have the possibility to choose which side to go to,
You want them to go towards their operated side. Now, your practical might be set up where you don't have that choice for a particular type of transfer. But when possible, you would want to do that. And so then, going way back to that whole neglected side, when possible, you don't wanna go to their affected side. Yes.
So neglect.
But if you can't choose, then you just have to make the best of it, if that makes sense. We just
Right,
wanna make
there's
sure
an
you guys are all
environmental
clear about
barrier.
that.
And we're not gonna be like in the situation of going back to vet though, like where when we're going back, we wanna use their affected side.
When we're going back, we wanna use their unaffected side, cause it's harder, right?
Oh, yeah,
to get back
unaffected,
in.
yeah, correct.
Typically, for your practical, you're only gonna transfer one way. You're gonna, I'm pretty sure is how they'll have it set up. And so when you can choose, you have your patient in your wheelchair, and you can choose where to put that wheelchair. If you're doing a total hip, you wanna choose to put it where they're going towards their operated side. Does that make sense?
Okay, so a neuro patient, the neglect, your stroke people, typically I would get them up on their strong or non-affected side unless for some reason we're working on the transfer and working on getting them focusing on that side. Ortho patients, you're going to get them up on their operated side or the weaker side. Okay, so if Julia just had a right total hip replacement, okay Julia, so remember you cannot bend forward. So once again, these people are not dependent, max of 2 people. They usually are pretty mobile as far as getting up. So I would still, okay, Julia, scoot your butt forward here. Good. Okay, you're gonna push from here and we're gonna stand up. Good, nice and tall. Good. Okay, hang on to me if you need to, but take a couple steps. Just a couple steps. Okay, reach back for the toilet. Good, turn and have a seat. Pretty easy compared to the other stuff you used to. Good. Don't overthink it, it's easy. I was telling the group back here too that there's a fine line between telling the patient what you're doing and being too wordy. So if you feel like you're talking, your patient's looking at you like, what are you talking about? Say, hang on, I'm gonna start over. We're gonna stand up and turn and have a seat in the chair. Enough said. You don't need to say, you know, don't flex past 90 and don't internally rotate, and they don't know what that means. You too for your documentation, but use language appropriate for your patient. For getting the patient into the car, the first thing to do is to put the passenger seat all the way back. So they have enough room between where they are and the dashboard. So always put the seat all the way back. Most total hip patients are using walkers. I have a doctor who says, I don't care, you will use a walker until I tell you otherwise. So I don't care how independent you are using that walker. So most people have a walker. So I would have my total hip patient back themselves up into the car. And then from there, they usually need family assist because there's not a lot of stuff to hang on to, then they're sitting. So because the seat, let's pretend I'm, let's see here, a right total hip. Because the seat is all the way back, we have the capacity to kind of shift your butt, get your leg in. Typically, they need a little bit of help to lift that operated leg up and into the car. And then from there, can kind of scoot themselves in while keeping that hip in neutral alignment. It's really hard to see if without there actually being a car here. Any questions about that? Seat back, sitting, backing all the way into the car, and then kind of slow turns, keeping the whole body straight as they step themselves in.
So when you say seat back, do you mean slide it all the way back, or do you mean recline it?
Slide it all the way back. Sometimes I will recline it. If you have really tall people, like your 6'4" gentlemen, sometimes they need both to really be able to lean back.
There's no restriction against leaning back, it's only a restriction about bending
Yeah.
forward.
Think about the angle, the hip is what we're looking for.
Good.
Okay. So once again, these people know they're coming in, and so there's like a whole joint camp protocol. They go to joint camp class, they talk about do's and don'ts, so people typically will bring appropriate vehicles and stuff to get to and from.
Right.
Sling, I would have 2 people, because if somebody is that low functioning, they need a Hoyer sling to get up, they probably can't roll themselves for you to tuck the sling. So if I had you coming over, okay, so for good body mechanics to roll, I like to hang onto somebody's shoulder and their hip. And then I'm kind of facilitating being in that kind of athletic stance as we're rolling to the other side. You're not here, you're close up and turning. Sometimes if I have the capacity, I'll have people like bend their leg to kind of help roll, but either way you have control over where their body is going. It's important to make sure you know where the head and the bottom is, because what you're gonna do is I would have you roll over. Yep.
Oh, stick your butt out, Lisa.
Huh?
Stick your butt out.
More? Yeah.
Okay, I like to roll the sling. Tuck, 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 tuck. Then I'm tucking it underneath her back and her butt. So then, as we roll her flat, then we switch and we're gonna go, so you don't have to do the legs, sometimes you can just roll. It's just a quick roll the opposite direction, and because I tucked it so much, all that material is already there. This is like a skinny person Hoyer sling. Okay, but you're already gonna be in a chair, so let's have you sit in. Are they disposable? Yeah. Oh, absolutely. Yeah, okay, snap, yeah, put them down. I've never seen it before. Okay, depending on your facility, things will be different. Sometimes Hoyers will have little pictures about what side is the head, what side is the feet, to make sure that you have it turned the right direction. And whether you have a manual or an electric, they have the capacity to widen the legs or narrow the legs. Sometimes depending on where you're going from, it's tight and I might need to widen the legs to get up close enough. Also make sure you don't hit your patient in the face with these, because sometimes you're so busy fixating on where the foot's going to be that this is like scary for people. This one's not have brakes. Is there a brake on this? Oh. This
Looks real sturdy.
Right, yeah.
We're gonna pretend the brakes are locked.
In your practical, if it doesn't have a brake, it would still be nice if you're like, I'm locking the brakes, and then, you know, just to acknowledge that, you know, to lock the brakes if, should it have some.
So sometimes they have different levels, mine just has one, but you would want it the tightest or closest to the patient as you can be. So don't do the outside one, because that's just a lot of loose material. So in this case, we would be tucking the blue. Okay, when you're doing the feet portion, you're gonna go in between somebody's legs. Then, well, I crisscross them and tuck them in. That way they can't slide out because that crisscross is in the way. Also, some things to note. This should raise and lower.
So did you see how she got that to lower? So if you need to lower it for your patient, there's a little knob right here. It says turn right to raise, turn left to lower. So.
And you're gonna want it pretty darn low, because otherwise it's really hard to hook it in. Yep. She had a good question, where do I put my hands? Just ask your patients, keep their hands in their lap. So we're gonna go to a chair, I guess. We have 2 people or by themselves?
By themselves.
Okay. I'll have somebody hold the, I guess, hold the chair. Okay. If you think your people are scared of slide boards, people are really scared of Hoyer slings.
Yeah, I would be.
Okay, other things that you
you will note, especially with men, is because it's really tight underneath the legs, it pinches in this area. And as I mentioned, people are a little robust, and sometimes, unfortunately, it just kind of cuts in for a couple seconds while we're getting them up from point A to point B. Did you guys see that? These are gonna go on the outside of her legs and then crisscross.
So is it different depending on
My
Do we have a
style you
different,
have?
are they all the same that we would be using?
I don't know the answer to that. I'm not sure how, but I can find out if it's gonna be that one. I would know how to use both types of slings that you see here today, cause they can both possibly be out at the sim, or at your practical.
Well, I even mean like the actual lift, are there different ones?
Oh, I think we just have this manual one.
There's an electric one right
Oh, haha, just
Yeah, but
kidding.
I thought that was a,
That's a sit to stand.
that's a stand, I thought.
Oh, I thought it was a lawyer. Just kidding.
Hey.
Oh, here we go. Get your workout in.
What is it? Sit to stand? Have a seat placement? No, that one doesn't have the like four shoulders to be a lawyer.
So now, if I was gonna do a Hoyer, I would probably move the armrest out of the way, so you don't have to get them up necessarily as high. But now these are.
This is a wrap.
Oh, they get stuck, yeah. So their butt needs to be up, but it needs to be up only high enough to get from point A to point B. So as long as you have clearance, they don't have to be way up in the air. So then from here, people are usually kind of scared, and then you can move it back.
Julia, how do you
So
feel?
move this chair, it's kind of out this way. So then as we're turning, I would probably make the. When you're getting somebody back into a chair, the biggest problem I see is that their butt isn't back far enough. So in real life, if you have a second person, that second person is holding them, making sure that their butt is gonna stay back in the chair. Okay, I remember how to lower. Hey, so remember when you go to do this, that this lowers fast.
Yeah.
Are the electric ones any slower?
Oh, yeah.
Yeah. It's like a smooth drop.
Oh, yeah. Huh? So for your practicum, I would just make sure that you know where all the levers are and just practice raising and lowering it. So how do you open the legs wide versus narrow? How do you get this up or down? And then. Does anybody wanna come actually look at her? How I have it hooked up before I. She's in it. Please feel free if you guys wanna practice raising, lowering, or touching her stuff is.
This is the wide, narrow,
Yes.
this is the raising and all.
Lift, someone lift me up. Do it. Do it.
Is the break on?
She's like, it's like not the best break.
break-ish? It's not,
Okay, you would be probably, for your own body mechanics,
right here.
having more.
Seems like it's not doing anything.
Yeah, it is.
Oh, this is like a manual jack on the car, it takes a while.
Yeah.
Okay. Am I allowed to go faster?
Go for it, yeah. Get a good tricep workout.
Yeah.
It doesn't, so for the legs, it doesn't matter if they're skinny or narrow, as long as you can get closest to the surface you're going
How
to
far
or
up am I
from.
going?
That's probably plenty, cause her,
Okay.
she is, you have enough leeway to.
I'm scared to let her go because I don't.
Before.
Someone's
Yeah.
back.
Front.
Okay.
I'm full interested.
Why don't you actually move her back to the wheelchair?
Okay.
So can you see here that
That's too
it was,
narrow.
it was too narrow, so that's where you might want to widen it to, you don't wanna accidentally grab the wrong lever.
And this we're gonna be doing solo? I would never wanna do.
Whoa, I feel like she just swung. Oh, good, you're right. Thank you.
Just
Makes me
drop it, watch
nervous.
both of your heads.
Okay, ready?
So to go down, this is where you have to turn it, turn this, but it goes very fast.
Whoa, that
So-
was so. What do? You just turn it. You just turn the knob and she drops in.
This would be on their back, and you're gonna be crossing
over. So this one's gonna go through that leg. See how it kind of makes a sling under your leg? And then this one's gonna go like that. So they're,
And their arms would go through like a back.
and this is like hang, yeah. So I'm trying to think how. So usually the top. There you go. Yeah. So then these will be in the back, and those are gonna be crossed through their legs. So the important thing to remember when you're using one like this, you have this opening, and that needs to be low enough so their butt's not hanging all the way out where they're gonna fall through. So when possible, you want it to be so it's covering their butt, or sometimes their butt's gonna stick out a little, but if it's this high up on their back, then you don't necessarily have enough going under their legs, and they might be more at risk for falling out. So when you guys go to do your practical and it's draped over the chair like this, and your patient's sitting here like this, you need to make sure that you're getting this underneath them. So that might be you telling them, okay, can you lean forward for me? And then you're gonna be pulling it down underneath them.
But now we have to be careful because this is total hip replacement.
No,
Is this still not,
no.
this is just, okay, I was
No,
still
this is
tying all these
just
together, like,
Hoyer.
like,
So, you know,
lean
can
forward.
you shift to one, you know, can you lean to the side, and you're gonna be pulling that underneath them. Okay, can you lean to the other side and helping them do that so that you're getting it all sorts of situated.
And then you
That makes
pull
sense.
one through the other.
So this one, if it's going under your left leg, you're gonna hook it on your right column. If it's going under your right leg,
I
But do you
still,
put them through
I
a-
still go like this,
that, okay, that's easy.
to
Yeah.
like, you just cross them.
Double protection, yeah.
Yeah.
Okay.
And then I always just double check, like, okay, as you start to, you know, is each leg kinda
It's not
a
all
sling, like under each leg as you go down?
Back far enough.
And so the chair
Yeah.
might be against something sturdy too, where it's not gonna go anywhere. So if you need a second person, we'll have someone there, but more than likely, it's gonna be a better setup where
Okay.
if you don't have a second person, you don't need a second person.
And with that one, you put your arms through the thing like a backpack?
No.
No, so
Okay,
this
good.
is the part that, and this is another good point that I wanted to not forget, and luckily, you need to make sure that you're not all wrapped around their wheelchair. See, like if we went to lift this up right now, we'd lift the whole entire, well, this part is gonna hook on your hooks right there.
And their arms are just in.
So the arms
here.
go
That's
over
what
it?
it's like.
Those arms are in. Yeah, so their arms are here,
I'm trying to visualize it.
it's just gonna be,
So think about telling your patient, put your hands in your lap,
so you're like,
and then you work
yeah,
around.
so you're gonna hook up there and there, and these hands are just kinda hanging it back.
If you start getting somebody up and think, oh wait, something's not right, that's real life. Put it back down, take your time, reassess. Don't panic and think they're gonna fail me because I didn't do this right. That happens, so take some, hang on, I know that wasn't right. Let me think through and talk through how we're gonna do this.
I mean, I do, all my lift is on with kids with cognitive impairments and physical disabilities. They're moving a lot. Like they're, you know, they're trying to kick their legs, they're rolling, they're not following directions, they don't sit still. So sometimes I have to unhook them, get them completely readjusted, like, oh, you just kicked yourself right out of that lift before I could even get it all hooked up. I mean, that's kind of what happens.
Actually, very similar to the car, if you think about it. So, with the tub with the car, let's say I am a right total hip, just for fun. Okay, backing up, you're squaring yourself up. Then you're then cueing your patient to sit. I oftentimes will cue my total hip patients to slide that foot forward as you sit, because if that foot's forward, it makes it impossible for you to break that 90-degree precaution. So typically we are sitting. Then I'm having the patient or somebody move the walker out of the way, scooting your butt as far back as you can, and you're kind of just slowly angling yourself. Typically they can lift this leg up and in, and then you either have to or kind of cue them to then put that up and over the shower until you're in. So somebody would use a bench if they cannot lift their legs up and into the tub versus a seat which sits just inside the tub. So for your future knowledge, a bench just makes it so that people don't have to step up and into the shower. So getting yourself back, slide to the edge, helping to get that leg out, scooting, and then kind of the whole body moving at once so you're not externally rotating that hip. Sliding, reaching this over, scooching, and you have this to get yourself to stand. Any questions? It's not hard. Forward as you sit. So then either the patient or you are going to move the walker out of the way. Slide your butt back, and then your whole body is going to kind of angle. So do you see how I can rotate this hip, but this one needs to stay straight? So as you're lifting in, kind of keeping it straight, it's not that bad. lifting it up and in.
Just little movements isn't that bad on the. So this is a lot like the car.
Very similar to the car.
Oh, yeah.
Very, very, very
Totally
similar.
makes sense. This
Okay.
is a, you are so smart.
Yes. Okay, so then scooching, lifting that leg up and over. Scooching, just turning your whole body movements. Then you'd have the walk there to the stand up.